After that, she can leave after the completion. Caregiver being there.
Yeah, I was a bit
Angel. Angels are old. The one in the bed.
Sister, she's looking attached. Compare Bengu to Angel.
Okay, so.
Good morning, everybody that's tuned in for the Q&A for the ECG month. Thank you very much for your participation. I'm just going to give another couple minutes, not too long, just to see if anyone else wants to join, and then we're going to start. Hope you're all doing very well. I'm waving at Kat, who's up there as Marden. I actually wanted to ask Pietermaritzburg Mediclinic, you guys sent 3 ECGs for us to discuss. Just to give everyone a heads up, we've got those 3. And then I've got 2 that I've brought. So we've got 5 to talk through. I'm sure that will take up our hour. They're all quite interesting. I just wanted to know from Pietermaritzburg why they chose those 3 ECGs. Were they just interesting looking, or were you struggling to interpret them? Was there anything about these patients?
They were, I just put them on the actual 3 lead on the monitor, and then they did look interesting.
Okay.
And of course the alarm, get an alarm at the start.
Okay.
Keep on going back to the patient. So then we got the 12 leads to be able to discuss.
Okay. Okay, cool. All right. Thanks. Okay, so I feel like ECGs is really like, once you're able to interpret them, you know, just the basic 12 leads, you sort of level up as an ICU practitioner. You definitely have more of an independent function because you can direct the timing of the care, and then also obviously your nursing care. And some of our ACLS treatments can be based on what we're finding on these ECGs. I think in today's times, we tend to be able to take them and obtain the 12 lead, but then we sort of just take a picture of them on our phones and WhatsApp them to the doctor. And some of these things that we're finding are actually quite urgent and, you know, need immediate care. And I think to sort of separate which tract of communication are we going to communicate our findings as a bare minimum, and then hopefully also to apply some of our ACLS treatment and then tailor our nursing care around what we are seeing is very, very important. Just simply sharing it over your phone on WhatsApp, I don't think is enough as an ICU practitioner, but it's a great skill interpreting ECGs for any registered nurse, I would say, or even enrolled nurses, of course, not excluded, but our accountability obviously rests on the registered nurse soldiers as always. Yeah, so I know we've got a very varied audience. Some people are a bit more advanced on them and some people are absolute beginners. But like I said in my in the YouTube video, JJ&J's YouTube video on ECGs and all these workshops I've been doing this week, for anyone, I see Sam Changfoot is there from Millpark. If the way I see ECGs is you can learn the theory, you can learn that you can go to the best ECG course of your life, and all these things are great and it definitely upskills your knowledge, but ECG is a very practical skill, and I do liken it to push-ups or burpees. So even if you're a beginner at push-ups, even if you go to the best training of push-ups, you cannot actually do them unless you practice. So I really think if you're on the floor and you're exposed to ECGs all the time, you should take one every day and have a look at it and try and do a systematic review of it, not just a quick, oh, this is a anterior MI. Actually go through everything and check out the PR interval and QT time and the whole shebang, regular, irregular, check all the quality things we have got the page that we've designed for a systematic review, which I'll share in our group. It's also on my slides for today, which we can have a look at, but we should start a culture of actually practicing together. Do it as a team in your unit or whatever team you have. If you're clinical facilitators, maybe also just sit together, make it a regular practice. It's like gym. And as soon as you stop going to gym, you kind of slip down again. And only once you start practicing again, do you sort of get your hand in it and keep up the skills. I also feel like in my own career, I was quite shocked when I actually landed in EP lab and saw how much more there is to ECGs. I don't think there's ever a limit. This is a continuous learning exercise. But anyway, let's have a look at our first one. Okay, let me just get there. So this is the first one that was submitted by Peter Maritzburg. Thank you for not putting any stickers on so that we are compliant with the POPI Act here. We should look at our quality things before we even look at anything else. And it would be nice to know the reason, but we know they obtain these basically just to put it into today's Q&A, but we should actually know, like, does this patient have chest pain? Was it a routine ECG? What medication is the patient receiving? What's the patient's blood pressure? All these factors can influence a lot of things on the ECG, and knowing what the patient is on helps with our decision-making process. So that would be nice to have the reasons, okay? We don't have a date and time, which we would want. We also need to make sure this ECG is calibrated correctly, which we can see on this ECG. So I'm sure you've seen on I don't know if you can see my mouse, but this rectangular shape here at the end of all the leads, the rhythm strips there at the bottom, you'll see the 10 blocks high, meaning that 10 millimeters is 1 millivolt, and the 5 blocks across is equivalent of the 25 millimeters per second. Okay, so this ECG has been calibrated to a standard setting so we can interpret all of it in the normal way. So at least we've got that. Okay. What else about the quality? There's no interference. Okay, so that's cool. I must say, if the only thing you take away from the ECG training we've given you, if you're a complete beginner, it would be to eliminate the interference. Before you send off your ECG or file it in the file, please, we need good quality ECGs. We need to at least have that, all right? So that's the least that the nurse can do. It's not accept ECGs with interference. Okay, so it's that sort of, I've showed lots of examples in the workshop, but all those like up and down sort of lines that are impossible to be waves, and it's usually created by electricity interference or metal or not good contact. Or I've said, from a practical side of working in these types of units for many years, our ECG machines are looked after so badly by the nursing staff. They're sort of pushed in the corner and the leads are just rolled like spaghetti around something, and they're hanging there and people ride over them with the wheels. So the integrity of the leads also makes a huge difference to the quality that we get. So we need to look after them a little bit better. Okay, so there's no interference here. If we just go through our basic principles and we work out, number one, the rate, we're going to look at the rhythm strip, which is lead 2 here at the bottom. Okay, and if we count the R waves, we've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Okay, and remember, a rhythm strip is 10 seconds worth of ECG. So if we're trying to get a rate, we're going to count the amount of R waves and times it by 6. Because our rate is per minute, right? And this is 10 seconds. So 10 seconds goes into 60 seconds 6 times. So we're going to do 12 times 6. So this rate is a beautiful textbook 72. I hope everybody agrees. If you lost or need a question, please type it in the chat box so that I can address it with you guys. Okay. Okay. Then we should use our that paper method that I demonstrated, where we take a scrap piece of paper, put it over the rhythm strip and draw little lines on our scrap piece of paper of the rhythm and move it along to check that the RR intervals are consistent. All right, if they're consistent, then it's regular. If they're inconsistent, it's irregular. You can count the blocks between the RR intervals, but the paper method is just a bit faster and maybe a bit more user-friendly. But just by the eyeballs, which we shouldn't do, it looks pretty regular to me. Does everybody agree? So we've got the rate and we've got the rhythm so far. Okay, cool. Okay, so now the next step is alphabets. Now we need to check our PQRST, and check that we're not dropping complexes, and check the shapes of these waves. Remember, the P represents atrial contraction. Can we see a P wave here? In the rhythm strip, I must say, it's quite difficult to see the P wave. So if you're struggling to see a P wave, you can move up to the 12 lead and look to see if you can see a P wave elsewhere. Okay, so we'll give you guys a moment to have a look there. This ECG's P wave is extremely small. The amplitude is very, very small. I would say the easiest lead, or the most evident lead of a P wave, would probably be AVF, or lead 2, which is the rhythm strip. So it is challenging, but if we look here at AVF, you can see there's some sort of activity going on here, and it's the same in the next lead. Okay, let's say these 3 complexes here. There is something, and it looks the same in each one. Okay, so that must give you a clue that there is something regular happening there. It's not interference because it's the same every time. There is a baseline, an isoelectric line, and then there's a section where there is activity. And that little bit of activity is consistent. Okay, so it is a bit of a challenge. Usually we want our P wave to be a nice 3 blocks wide, nice and rounded, and not more than 2.5 blocks in amplitude. That would be great. So this is a bit frustrating after teaching you guys all that, but this is real life ECGs, okay, not perfect examples. So don't be fooled by that. But what is more interesting perhaps on this ECG is before these little P waves, or what I think are P waves over there, you can see quite a small perpendicular line. And you can see them in other leads as well. Look here in V3. There's actually 2 of them. Can you see those over there? I'm not sure if you can see my mouse. But in V3, we've got these little perpendicular lines. And I hope you guys can remember what those are. They are pacing spikes. Okay. So also, usually pacing spikes are a little bit more bigger in amplitude so that we could see them maybe a bit clearer. But there's definitely 2 pacing spikes here in V3, and you can see in V4 and V5, some of the more of the anterior leads, you can see that pacing spike, especially the one before the QRS, is more prevalent there. But if you look at V3 specifically, you can see there are 2 pacing spikes, and we've got electrical activity after both of them, which indicates we've got double chamber pacing. Okay, I hope everybody can see that. Also, what gives away the double chamber pacing is the QRS complex that is wide and a little bit bizarre and large. Remember, we don't have electricity going nicely through our natural conduction system here, through the SA node, AV node, bundle of His, through the bundle branches and Purkinje fibers, beautifully down the septum. We've got electricity being delivered through a right ventricular lead, and it creates a bundle branch looking shape. Okay, because that's essentially what's happening. The electricity in the ventricles coming from the right ventricle and traveling across to the left ventricle. We have a little bit of a delay, and then you get a bundle branch looking picture, and that is absolutely normal in pacing. Okay. So for those of you guys who first looked at this ECG, I wouldn't judge you at all for initially thinking this might be a bundle branch block, because here we've got the bunny ear looking picture here in V1, okay, with the M shape there. And we said the other lead we look at is V6, and there's a W shape there. So essentially right bundle branch looking picture. But with the pacing spikes, that rules that out. And we can only go with double chamber pacing. With basic ECGs, I would say don't attempt to look further at ST segments or any of our MI considerations. Okay. However, we can look at our T waves, which look okay. Does anyone else have anything else that they noticed here on this ECG? Does everyone agree that it is double chamber pacing? Can you all see it? Please type in the chat box so that I can see that you guys know. Okay, we're happy to move on. No questions about this one. Okay, let's move on to number 2. This one was also submitted by Peter Maritzburg Mediclinic, and I'll give you guys just a moment to have a look at it before we start talking about it. I'll talk a little bit about the quality stuff. So we're in the same situation again. We don't have a sticker, which is fine for this Q&A, but we would like it to be identified in our real practice. Hey, please don't ever act on an ECG that's not identified. And please don't file an ECG or capture an ECG on CareOn or whatever electronic or medical records you're using without it being identified. Okay, and while we're at it, I may as well just preach again that can you please make a few copies of your ECGs, especially the acute ones, because we know our doctors tend to uplift them. Okay, please encourage them to wait for a copy instead. But I find that they take the originals and then we have nothing in the hospital files, and it's a big risk. Okay, we have no proof that the patient has MI. The rest of the team has no opportunity to compare ECGs with, say, before angio, after angio, before surgery, after, because those before ones are all uplifted. So please make a few copies, or if you've run out, please encourage the doctor just to wait a minute so that you can just make a copy, but don't give them the originals. Okay. Okay. All right, so we're in the same thing. We've got our calibration. We can see our 25 millimeters per second, 10 millimeter is 1 millivolt. We've got our nice calibration sign there, the rectangle. Okay, so we can interpret this ECG with normal parameters. We don't have the indication, once again, don't have the vital signs. Please make an effort. Change the culture in your guys' units to write a lot of information on your ECGs. Okay. None of this blank ECG business, right? We need the info. Okay, so let's have a look now at our rhythm strip. Just start, whenever you start, just starts with the rate and rhythm, and it starts to push you in the right direction. Okay, so let's have a look here. Let's count the R waves. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. Okay. 13 times 6, remember we are always timesing by 6, so that we can work out the rate per minute. This is the rate per 10 seconds. So 13 times 6, 78. So that's within the sinus rhythm range. All right, so let's have a look. Is this rhythm regular? And we should use some sort of method to check that it is regular. We shouldn't eyeball it. And as I'm saying that, I'm telling you, my eyeballs are saying it looks regular. Terrible. Okay, but we should actually take a paper and have a look. Okay, cool. Let's do our alphabet. Okay, so now we're looking for P's. So here's P, Q, R, S, T, 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 the whole way. Hey? Go through the whole rhythm strip and just label it just to make sure that there's a P before every QRS. We're not dropping QRSs. The shape of the P waves, I wouldn't say there's much to talk about there. It's not an obvious P matrale or P pulmonale. It's pretty much rounded. Okay, and it's the normal duration, our PR interval. Let's have a look at that. If we remember, when we measure anything, any of these intervals, we measure, for example, now from the beginning of the P to the beginning of the QRS. So you must find that beginning of the P landing on a line, not in the middle of nowhere. So if we look at the second complex here on the rhythm strip, okay, there's our P wave. And we can count 1, 2, 3, 4, 4.5 blocks. And it shouldn't be longer than 5 blocks, eh? 0.2 seconds. Each small block is 0.04. So 5 is 0.2. And anything beyond that, we start talking about atrioventricular blocks. So we at 4.5, which is about 0.18. So we're within the normal range. Okay, so no atrioventricular block here. Okay, so what else are we seeing? Let's move up a little bit more. We can see the QRS complex is a little bit wide, or a better word for QRS complexes is broad. Okay. Ideally, we want them to be less than 2.5 blocks wide. And if we look at these ones that are very prominent here, the anterior septal side, they are leaning more towards 3 blocks wide. So they're a little bit wide. Okay, and what else can we see? Does anybody else agree that we are seeing the bunny ear picture? I know these are not the leads that we typically look at for bundle branch blocks, but have a look here at AVL. There's definitely a double R wave. Can everybody see that? So there's an R there and there's an R there. There's a notch within the QRS complex, which must make us think it's possible that our one ventricle could be firing slightly slower than the other. That's what creates that sort of picture. If we look at the rest of our ECG, it now becomes more prevalent that we've definitely got double R waves. Okay, look at V5. There's 2 QRSs overlapping there. Okay, so if we're thinking bundle branch block, we need to look at V1 and V6 to use our William and our Morrow. Remember, we need to ascertain is this left or right bundle branch block. And the little trick that we use are the 2 words William and Morrow. William for left. The letters in between in the word William are LL. So that's to help us to identify a left. And Morrow has got 2 R's in the middle, and that helps us to identify a right. And the 2 leads we look at are V1 and V6 for this. And if we see a W shape in V1, or alternatively a negative, okay, so the W is over there in V1, and the M, or a positive QRS complex in V6, then it's a left bundle branch block, which is the case here. That's my best guess. For right bundle branch block, we would see an M shape in the V1 and a W in V6. Okay. So even though in those two specific leads, we're not seeing the beautiful, easy to identify bunny ears, but we see them in many other leads within the ECG. But to be able to guide us to the right and left, we go to V1 and V6, and we can see that is definitely M and V1 is W. So this is a left bundle branch block. Okay. I appreciate this example a lot because the examples that we teach are much more obvious, and we make it like we choose ECGs where it's easy to see, where this is real life. This is what you're going to face on a day-to-day basis. And to apply that knowledge in these real ECGs is what we're practicing now. Okay, so just remember, don't get overwhelmed. Just if you see the double R waves or the bunny ear shape through many leads, more than 2 leads in the ECG, okay, then move on to V1 and V6 and see if you can make out a William or a Morrow. Does anyone else have any questions about this one? Can everyone see the bundle branch block? This isn't the easiest bundle branch block, definitely not to identify. So I'm grateful that they've brought it to us here. Okay, cool. Let's move on. Okay, this is the last one that Peter Maritzburg submitted. Exactly the same quality story as the other two. So I won't talk about that again. We can just jump straight in. Let's go to lead 2, which is our rhythm strip, and count our R waves. So we've got 1, 2, 3, 4, 5, 6, 7, 8, 9. 9 R waves, and we times it by 6 to get our rate. So 9 times 6, 54. Okay, so we are slightly on the bradycardic side, hey? So it would be very nice to see this patient's blood pressure. Remember, whenever you've got a rate that's less than 60, first 2 steps is a neuroobs and a blood pressure. So you go up to the patient, do a new blood pressure to make sure there's enough cardiac output, all right, so that the patient's getting enough perfusion. And we talk to the patient a little bit. Hello, are you okay? Talk to them, try and do a little bit of an assessment to time, place, orientation, because if they're not receiving enough blood to their brain, they're going to get a little bit agitated and confused. Okay, so if the neuroobs are intact and the blood pressure is in acceptable limits, we know they're coping all right with the slower rate. But obviously, if there's abnormalities, it could be because they're not getting enough perfusion, and then we need to act on this abnormality of a lower heart rate. Okay, all right. So we don't have that information. We're just on the ECG now. Let's have a look. Is it regular or is it irregular? So we would take our piece of paper and go through and check our R wave, RR intervals. And I hope you guys can see this RR interval is a lot shorter, okay, than these ones over here. Up until that point, I think it's pretty regular. This looks very regular to me here, but then this one over here messes it up, hey. And then we've got, again, a R interval, and then here, a short one again. So it's irregular, okay. Can everybody see that? All right, so let's then move on. Once we've got an irregular rhythm strip, all right, we're not strictly sinus rhythm. Okay, sinus rhythm, we say is regular. We need a PQRST on every single complex. We need a rate between 60 to 100. So we're already a little bit slow, and now we've got irregular. All right. So when we've got irregular, we start thinking, is this atrial fibrillation? All right, that's our most common one, perhaps. And On the baseline, we will see a fibrillatory line for atrial fibrillation. Hey, we won't have a nice defined P wave. Remember, we've got foci firing off in the atria around the pulmonary veins that cause a fibrillatory baseline. And that is the condition for AF. And I just want to remind you guys once again to please increase the scale of your ECG strip or the rhythm strip you're using on your monitor for ECG monitoring so that you can see the P waves from where you are charting in the ICU setting. Okay, if it's not big enough, you're not going to be able to tell what is happening with that rhythm. Unless you can actually see the P wave every time before the QRS, you cannot be writing sinus rhythm every hour. Okay, so up the size, make the scale optimum so you can see a P wave from where you are, so that you can quickly tell, is it AF or what is the scenario? Okay, if it's too small, it's just going to be flat and you won't see any P waves and you won't be able to tell. But on our 12 lead, we don't have that issue. We can see nice P waves. All right, there are nice P waves here. So this is not atrial fibrillation. This is something else. So we rule out atrial fibrillation. Okay, what else can make your ECG rhythm irregular? Remember, those that have done the training, the atrioventricular blocks, type 2, Mobitz 1, Venkerbach, and Mobitz 2, both drop QRS complexes. Okay, so they often make, they will be a cause of a rhythm being irregular. So let's have a look here. If we go P, QRST, P, QRST, P, QRST, P, QRST, P, QRST, then we've got something added on to the end of that T. Then we've got a QRST again, and then P, QRST, and then another something added onto that T wave, and then QRST, P, QRS. Okay, so it looks like we are not dropping. Okay, we are not dropping QRS complexes. There's no P and then nothing. All right, a non-conducted P wave. So this is not Venkerbach and it's not Mobitz 2. Okay, so remember what I said to you guys. As soon as something comes in that looks early and then there's a compensatory pause, we must start thinking of what? Ectopy, hey? And what is ectopy? It's got many names. Extrasystoles, ectopy, premature contractions, all right? So let's see, is that the case here? All right, so it definitely looks like something has come in early here. And when we're thinking of ectopy, we need to decide, is it atrial or is it ventricular? And if it's ventricular, it has a wide and bizarre QRS morphology, but we can see our QRS looks pretty consistent with our normal complexes here. So it's probably coming from above the AV node. All right, so the AV node is catching whatever electricity is being given it to it here, and it's generating a normal QRS the same as these ones over here. Okay, so what I think is happening here is we've got atrial extrasystoles that are coming in here just at the end of the T wave, and they are then conducting through the AV node a normal QRS. There's our T wave, and you'll see there's a little bit of a compensatory pause. It's a bit longer, this RR interval, than here in the beginning when we are having normal sinus rhythm. Okay, then we have a normal sinus one again, and you can look at the shape of that P wave. There's the QRS, there's the T. Here's our atrial extrasystole, and it is a different shape, all right. And then it conducts, and there's our compensatory pause. So in our rhythm strip, we can see two atrial extrasystoles, Okay. I hope everybody can see that. So if this was my patient on the ICU chart, I would write sinus rhythm plus AEs. Okay, because there's definitely sinus rhythm, but it's these atrial extras that are causing occasional irregularities. Okay, but most of the time this is actually regular. So we're going to write sinus rhythm plus AEs, not just sinus rhythm. Okay, we need to acknowledge the AEs. And remember, they're not that dangerous. We all have them to some extent. But as the ICU practitioner, you need to note them. And you need to note how frequently they're happening. And if you're noticing, we should be checking our electrolytes routinely in any case. But if we see a problem where they're sort of increasing or becoming more prevalent, we will check our electrolytes again, potassium, magnesium, make sure we've corrected them, maybe aim for a slightly higher potassium in this case then. Any dysrhythmia, we aim for a slightly higher potassium to about 4 usually. Obviously, you must discuss that with your doctor, but once your electrolytes are sorted and you're still having these, you must report it, and they can give some medications like Corolan, for example, which take care of atrial dysrhythmia. Okay. Okay. Because if they, like in this example here, it happened every second one for these 2 beats. So it would be nice to have this patient on the monitor and see how frequently these are actually happening. Because to have it's so bad that we're now having like almost a bi-Gemini picture of atrial extras that can affect our cardiac output, all right? To have these compensatory pauses so often. So yeah, on their own, they're not dangerous, okay? But we should be monitoring and seeing how prevalent. And obviously, if they're worsening, they can become a problem. Okay. Any questions on the 3 ECGs from Maritzburg? These atrial extras are quite common and they trip everybody up because it makes your rhythm irregular and everyone thinks it might be AF, but it's just these darn annoying atrial extrasystoles. Okay. I hope everyone can see. Okay, so let's move on to what I brought. All right. So this is ECG number 4, Love From Me. This is something I didn't teach you guys in the YouTube video or the workshop. So it's a little bit more advanced now. I just want to give you a moment to have a look. This ECG has got 3 rhythm strips, 3 rhythm strips. V1, 2, and 5. And that's quite a cool practice, I think, that you have 1 rhythm strip from each area of the heart. Remember, V1 is going to be anterior, V2 is going to be inferior, and V5 is lateral. Hey, so they've got a rhythm strip for each area of the heart, plus the 12-lead ECG. Okay, so what are we seeing here? We can evaluate this ECG in the same way. So we'll look at our quality things. We'll work out the rate. We can see that our rhythm is regular. I must say a little bit of a challenge in this V5 to see the P wave. If you're struggling to see a P wave, I always recommend that you look at V1 and V2. Those septal anterior leads are the closest to our atriums. And there you can see a P wave a little bit better. Can see P waves in other areas as well, but more prevalent here in V2. Okay, our PR interval looks decent, normal interval there. Got a P for every QRS, but what is very much prevalent in this ECG, and I hope you can see this ST elevation. Hey? So remember, we're looking for our J point. So let's go to where it's the most obvious. I would say, let's look at V4. So our baseline is over there. And if we look at our J point, we're at least 1, 2, maybe even 3 blocks elevated. Okay. It's definitely ST elevation V6, V4. So anterior lateral. It's all elevated. V1 we can see is actually negative, and we've got a T wave inversion. Our high lateral also has a bit of ST elevation, although it's less. And our inferior side, we have our inverted T and a negative wave. What is interesting, and why I brought this ECG to you guys, and some features that I wanted to discuss with you guys about it, is, can you see your PR interval is depressed? Okay, so we've been teaching you guys about ST segment elevation and depression, and we've definitely got those abnormalities here. Okay, but now we're adding PR interval depression. Okay. Okay, so let's see, what is this now about? Okay, so where we normally measure our PR interval from the beginning of the P to the beginning of the QRS, can you see between the P and the QRS, we've got this down-sloping PR interval here in lead 2 and in lead 1. Which other leads can we see it in? I think it's the most obvious in those two, hey? And I think a general sort of rule in ECGs, although it's not absolute, but as soon as you've got an abnormality in 2 consistent leads, it is significant. Okay. Can I ask you guys just to mute yourselves just while I'm quickly explaining this one? We can unmute at the end, okay? And you can ask me. All right. So we've got a depressed PR interval, and that is a classic feature of pericarditis. Another classic feature of pericarditis is this concave ST elevation, is what I think they call it. Looks like a saddleback. Eh? Can you guys see the saddleback? So it's this rounded ST elevation. Can you see it there? Lead 1 has got it nicely. Lead 2 has got also concave. AVL 4, 5, and 6 all has that saddleback looking ST elevation. And we've got a PR interval depression in 1 and 2. So it's below the isoelectric line, our PR interval. And that must make you think about pericarditis. Let's have a look at what that is. So pericarditis is inflammation of the pericardium, the fibrous sac around the heart. Symptoms typically include sudden onset of sharp chest pain, which may also be felt in the shoulders, neck, and back. And pericarditis is quite a common thing in the ICUs. Okay, we do a lot of pericardectomies, pericardial windows, and I want you guys to go and have a look at the ECGs and see if you can find these features, okay? But also in your admissions with people with chest pain. So we've got widespread concave ST elevation and PR depression throughout most of the limb leads, which are 1, 2, 3, AVL, AVF, and our precordial leads V2 and V6. We should have a reciprocal ST depression and PR elevation in AVR. Sinus tachycardia is also common in acute pericarditis due to pain or pericardial effusion. Okay, so what are the classic features? Widespread concave ST elevation, which is that saddleback. Okay, it's that saddleback shape. And the PR depression throughout most of the limb leads and precordial. And you'll see here these 2 zoomed in examples here. Can you see the concave ST depression? Remember, we measure our isoelectric line basically on the P wave, we see our PR interval is depressed, our ST segment is elevated, and it's that, it's the concave shape. This is in V5. And then the reciprocal change that we will see is in AVR, which is normally negative anyway, but our PR interval in that case will then be the opposite. It will be elevated, and our ST segment will be depressed, but still that curved shape, but now in the opposite form. So if you see these features, you can report and say you think you're seeing depressed PR intervals with a concave ST elevation through the ECG, and together with maybe your chest pain or your tachycardia, you are wondering if the patient doesn't have pericarditis. Okay, and then obviously together with your multidisciplinary team and your doctors, you'll take it further to do more investigations. Okay, will you guys be able to do it? Are you going to thumbs up so that I can see? Pericarditis. Okay, I think when we do more advanced ECGs, I think we will plan an advanced ECG workshop at some stage. I'll teach you guys how to look for pulmonary embolus as well, but I think pericarditis is a little bit more achievable. Pulmonary embolus is a little bit more complicated. We'll do that another time, okay? But those are the other two conditions that we haven't taught as yet. But I always know the people that dial in for Q&A are the people that are extremely interested. All right, so I always like to put something a bit more interesting in. So this week, it was pericarditis. Okay. What is the time now? Let's have a look here. We've got about 13 minutes left. I've got one more ECG that I'll show you guys, and then I'll open it for any questions. This one we have taught in the workshop. It's not a beautiful, nice, pretty ECG. Hey, it's not a nice copy, but let's see what we can find in here. All right, so our quality stuff is again missing. Our calibration is right off of the screen. We do, however, see the speed of 25 millimeters per second, and our limb leads 10 millivolt. 10 millimeters is 1 millivolt. So at least the calibration is there. Let's look at lead 2 here at the bottom. We're going to calculate our rates. So it's 1, 2, 3, 4, 5, 6, 7. 7 times 6. Okay, 42. So we are bratty, hey? We are slow. So remember to do a neuro check and a blood pressure check, hey? Okay. Usually at that rate, we do start to get symptomatic unless it's a hell of an endurance athlete. All right, so next up, is this regular? So we should check with the paper and measure the RR interval properly. But if we eyeball it, it looks like these R waves are regular. Okay, so now we need to figure out, is the sinus rhythm? And we're going to do that by labeling these waves. So we've got a bit of interference here. This is probably a labored breathing situation, right? Which makes me think the patient is probably symptomatic. We should try and avoid this when we capture an ECG, but if the patient is sick and struggling, it might be a bit of a challenge, okay? But we could lift up the controller box on an arm and try and see how we can get the labored breathing out of the way so that we have a nice flat baseline. Okay, not always possible, but let's look here. Okay, so that looks like a P wave over there, a QRST, a PQRST, PQRS, something's going on here, T. I'll put a question mark there if this was me. PQRST, PQRST. That looks like a P to me. And then another P, QRST, with something over there, PQRST. Okay, so we're not having that nice PQRST every single time. There seems to be something cooking over here with two P's consequential to each other. And then also within the T wave, we can see there are other things hiding in there. All right, so this is not sinus bradycardia. It's a atrioventricular block. So let's go through it. Is it first degree? How are we going to check that? We need to check our PR interval. Hey, so let's have a look at our first one in this complex. We've got 1, 2, 3, 4, 5, 6, about 7 blocks, which is prolonged. It should be less than 5 blocks. This one is 1, 2, 3, 4, 5, 6, 7, 8, 9, about blocks. So it's getting longer. Here, it's even longer. And from this P wave to QRS, it's even longer. Eventually, it does look like there should be a QRS here between these 2 P waves. So did it drop a QRS? If it does that, if we've got longer PR intervals that are prolongating every time, and they're getting longer, and we drop, that is classic Wenckebach. Hey, second degree Mobitz 1 is Wenckebach, where we have a prolonged PR interval with eventually a QRS drop. But the problem why I say this is not that is because it's regular. Hey, if we're dropping QRS complexes with Wenckebach, we will have an irregular rhythm. Mobitz 2 will also have an irregular rhythm with a random dropping of the QRSs. Here we've got a regular QRS complex. Hey, okay. So at this rate, we should also be thinking, is this a third degree block? Third degree blocks are not strictly 40 and below. You can get some that are higher, but typically our AV node will have backup pacing at around 40 beats per minute. All right, so we sort of in that range. So let's have a look. Is this a third degree? So we said our QRSs are regular, which fits in with the node pacing, nodal pacing. Let's have a look at our P wave. So there we've got a P, there we've got a P, there we've got a P, there we've got a P. And that looks pretty regular. But as soon as we get to these 2 that are close together, we should take our paper and put 2 lines down for those 2 and track it along this rhythm strip. And you will see there's another P wave hiding between each one. So on this side, it's a bit easier to see. Over here in the T wave, we see another P. So I would say there's a P, there, there, there. There's one hiding in here somewhere. It would be easier to see with the paper. There's a P. Here's one at the end of the QRS complex. Here's one. Here's one just before the T wave. There's another here. There's probably one in that T. And there's the P that we can see. So if you look at those and you put the little lines on the paper, you will see that there's a regular P wave here as well. That's much faster than the nodal pacing that's giving us our QRS. So what does that mean? It means the relationship between atria and ventricle has been lost. They're not firing off of each other. They're firing independently from each other, which is a third degree block. Okay. I hope everybody can see this third degree block. And then obviously we'll do our neuro check, blood pressure check. And if this patient's very symptomatic, we might even transcutaneous pace him. Okay, until he's taken to cath lab and sorted out. If this is a symptomatic block, he might need a temporary pacemaker. We might need to work him up ischemically to make sure that the right coronary artery isn't the cause of this problem. Doesn't look like it from this ECG. Will depend on cardiac enzymes. And perhaps if it's not drug related or if it doesn't have an explanation, we might need a permanent pacemaker for this patient. Okay. Okay, you guys are welcome to unmute yourselves if you want to, and we can quickly talk. We can go back to any of these ECGs if there's a question. Does anyone have any question or comment? This is your chance. Does anyone want to talk? Are you guys satisfied with these 5 ECGs we discussed this morning?
I don't know.
How's it? How's it?
In 24 years of doing ECGs, I've never ever heard of the pericarditis thing. So thank you so much. That was brilliant. So the saddle
good.
and the PR interval depression. Yay! Learn something new.
Right.
You learn something new every day.
Yes, this ECG knowledge never stops, guys. Never. There's no ceiling. You can constantly learn more. Yeah, I think the pericarditis is very achievable for nurses to be able to identify. The features are quite obvious, and it's usually through the whole ECG. You know, it's not just one little lead hiding there. That concave looking ST segment saddleback vibe is usually through the whole thing. And the PR interval that's depressed is quite easy to spot, you know, if you put a ruler down on that isoelectric line. And that's, you know, it doesn't really exist in any of the other conditions, very specific to pericarditis. So I feel like it's one that the nurses can really add value to and pick up early. Yeah, I'm glad to hear that, Kath. Thank you so much.
I'm going to race down to the ICUs after this to like go and spot pericarditis everywhere.
Look, the easiest thing to do if you're now new to it, right? So no one expects nursing staff that have just learned now about this to go and diagnose a pericarditis. But what you can do now in your practice is when we have patients that are diagnosed with pericarditis or that have come in for pericardial windows or pericardial synthesis, pericardial effusions, go and have a look now at those ECGs. And then once you can see on those, you know, on those patients, you can see the saddleback, you see the PR interval that's depressed, you start getting it, you know, in your practice, and then you'll be able to diagnose when you come across the ECGs. Okay, obviously, if you can do it before that, wonderful. But that would be like the next natural step, is to go now specifically go look at patients with pericarditis or any of the pericardial abnormalities. Go and correlate now what you've learned with the ECGs in your practice, and then you can start applying it. Yeah. Cool. Did you guys spot those abnormalities in the ECGs you guys sent? Yeah, got them, hey?
Yeah.
I love the atrial extras. They're so tricky. They trick everybody. And people, you know, especially when the patients are just on the monitoring. And it confuses everyone terribly. They remind me of the little jokers in the pack. They're playing tricks on us all the time, atrial extras. Yeah, any other questions? Are you guys good? Remember, if you ever stuck with an ECG, you should definitely communicate with your doctor, right? But if you're just from an interested point, please send them to me. I love ECGs. I don't mind practicing with any of you guys. So if you've got an interesting one that's stumping you, take a photo as good quality as you can. You can send it over WhatsApp and say, how's it, Renee? Please help us. What's happening? What do you think of this ECG? And we can discuss it together. Okay. But please, clinical facilitators, I see there's quite a few of you guys on today, which is wonderful. Try and encourage the staff to develop some sort of a regular practice. Okay. Doesn't help you do an ECG workshop and do no practice. In 2 months' time, you'll forget everything. Okay. Okay, fantastic. I also just wanted to drive home, maybe as a closing thing. I did mention it in the workshops, but remember when we place our electrodes, we've got our 4 limb leads and we've got our 6 precordial chest leads. And our limb leads give us Einthoven's triangle. And Einthoven's triangle can only give us an inferior picture and a lateral picture. Our anterior views can only come from chest leads. And unfortunately, that means that if we're looking after cardiac patients, we're concerned about anything anterior, they have to be on 5-lead monitoring. 3-lead monitoring is not adequate, all right, for cardiac patients, I would say, but specifically patients with anterior abnormalities. If you've got an anterior infarct or post-CABG that they've worked on the LAD, you really must have 5-lead monitoring so that you've got the anterior view. I've seen that in quite a few of the hospitals in this region, but I'm sure it's a thing that we must maybe just highlight again everywhere. Cardiac patients deserve all the views to be monitored. Okay, so please try to advocate for 5 leads for cardiacs. Okay, I think that's me finished preaching. Thank you so much to the people who joined. It's a very small group, but I know the clinical facilitators have big reach, so I'm very excited by that. Thank you for your dedication to ECGs and upskilling cardiacs. Bye from JJ&J and from me, Renee. March is all about cardiac output, so look out for that. We'll see you guys around. I'll make a plan with your units to talk about cardiac output next. Have a wonderful day. Cheers. Bye.